Hello, my name is Christopher Voscopoulos of Medical Specialist Associates, and in this video we'll show you how to place an ultrasound-guided suprapubic catheter. Thanks for watching, and thanks for learning with us.
Medical Specialists Associates, making medical education more accessible.
Ultrasound-guided suprapubic catheterization, performed by Christopher Voscopoulos, narrated and edited by Manuel Gutierrez. Indications include acute urinary retention when urethral catheterization has failed, urogenital trauma with damage to the urethra, or long-term catheterization such as in neurogenic bladder. Contraindications include cases with high probability of bladder cancer, abdominal incisions with high likelihood of adhesions as this increases the risk of perforation, and pelvic fractures where urethral damage is imminent. Complications can include small bowel perforations, urinary tract infections, blockage, or even catheter retention. The materials should include a sterile field with gloves and surgical gown, 2 10cc syringes with 18 and 25 gauge needles, a suturing kit with a needle holder, lidocaine, suture, a 2-0 silk non-absorbable was used, chlorhexidine, a collection bag for the urine, pre-filled syringe with saline, and the introduction complex, which includes a Foley catheter with a stylet encased in a Bardex lubricath introducer. Always check the catheter balloon can be inflated. The Foley stylet is introduced, the tip is looped, and the two are slid inside the Bardex introducer. The first step in the procedure is to find the location of the bladder. An estimated 2 centimeters above the pubic symphysis is often used. The bladder sits behind the anterior pelvis but can often be palpated suprapubically, especially when the bladder is distended. An ultrasound is a useful tool for confirming location and urinary volume. Once location is confirmed, inject the area with lidocaine and make a small incision for the introducer. Double-checking balloon inflation is always recommended. The Bardex introducer is carefully inserted until it reaches the bladder. The stylet and Foley are advanced forward slightly. The stylet is then removed and a syringe is used to suction the Foley catheter. Urine confirms correct placement. The Foley balloon is then inflated with saline, and the lubricath introducer is peeled away from the Foley catheter. The Foley catheter is then connected to the urinary draining system. Ultrasound is once again useful for confirming placement. To secure the catheter, a simple suture is made. One side of the suture is then used to encircle the catheter. This is then tied with a surgical knot. Always make sure that the urine collection system is working. Thanks for watching.
In this particular segment, I wanted to take the time to emphasize some points about our technique. We use ultrasound. That is in contrast to the blind technique. We find that the use of ultrasound has at least 2 distinct advantages over the blind technique. The first is that when we use ultrasound to identify the bladder, we're able to identify the exact angle that we want to go into to get into the bladder on a first pass. The second advantage is that we're able to determine the depth of the bladder. Now this is important because in the blind technique, it is possible to not only just miss the bladder, but to possibly go through and through the bladder and to possibly damage such important structures as the rectum. In the video that we showed, we happen to use the BARD suprapubic catheter, which I have here with me now. And with that particular manufactured product, you have a trocar with a hollow opening through the trocar here. And what we simply do in our technique is we're able to make our incision, and then once we make our incision, we simply pass the trocar into the bladder, and then we would simply thread our catheter then into the bladder, and then since this has a hollow opening on one side, we're able to peel this away. Other products use a peel-away dilator trocar instead. And so if you had that particular product, you would still find your bladder with ultrasound, you would determine your depth, you would make your incision, and then you would simply put your trocar peel-away dilator into the bladder, and then once in the bladder, once you had return of urine, then you simply go ahead and put your suprapubic catheter in. Once in, then you simply go ahead and peel away the dilator to remove it. And lastly, there are some products that do not have a balloon at the end of the suprapubic catheter. In both the BARD and the peel-away dilator products, you do have a balloon. And once you inflate this balloon here, it has some advantages in that it helps to prevent the dislodgement of the catheter once it's in the bladder by having a little more resistance if it gets pulled. However, in the devices that don't happen to have a balloon, what they have instead is a little circular apparatus at the end of the catheter here. And what you do is you simply put that flush to the skin, and then you can suture around that circular endpoint, and that provides some additional strength, again, from it not to prevent it from being pulled out. Thank you so much for watching and learning with us today. If you're interested in taking this class for credit, or if you're interested in our other services, such as our direct clinical care services, please visit our website at www.med-specialist.net or click on the link in the description below. Also, make sure you subscribe to our channel to stay up to date on our most current content and educational opportunities.